So this time you are here for a little longer period. Otherwise, you are just here for 1.5 day. Okay. So we are going to talk about the principles of assessment, and I'm going to brief you about the fundamentals. Rest you can read yourself. Of course, in these sessions we can only touch the fundamentals. In a short time of 9 minutes, I can only. जी, अब ये चलती जाएगी. Okay. So there are various types of assessments. We have formative, we have summative, and both have their pros and cons. This formative type of assessment is mostly called as diagnostic, since you are able to find out the problems in a certain subject or a student, and then you can also guide the student accordingly. It's done during the course, provides feedback to the student on his or her progress, and provide feedback to the teacher with the data for modification of the teaching process. The summative assessment is done at the end of the period. It's sort of a certifying type of assessment, and for placing the student in order of merit, and during giving any certificate or degrees or awards. Assessment is a vital and powerful force in teaching and learning, ensuring continuous professional development, and the feedback inherent in any form of assessment has a significant educational role shaping motivation and future learning. It also ensures that our graduates and colleagues are up to the practice and able to provide a high standard of clinical care. It helps us in assessing the student and ranking them, measurement of improvement in a student, and to diagnose the student difficulties, evaluate method of teaching, and motivate student to study. Trends of assessment. The old assessment methods were factual recall. You will ask a question from the student, and the student will answer the questions, and the factual recall is there. Whereas the newer trends are the application and synthesis of knowledge, ensuring that the tests are reliable, valid, and acceptable, removing wherever possible subjective biases. Like we have OSPEs, we have TOEFLs, and we have other methods of assessment which have actually removed the personal bias of the examiner, and assessments practices aligned with the socio-political concerns, ensuring that healthcare practices are there to be done, and competency-based assessment and use of simulation where developing expert performances associated with the inappropriate degree of other things. So we have application and synthesis of knowledge. We have the test should be reliable and valid, and the assessment practices should be aligned with the other concerns like socio-political, and it should be competency based. The educational paradigm, as you all know, that we have certain learning objectives, then we have teaching methodology, and then we have assessment. So they are all connected with each other, and the objectives should match with the assessment, and the teaching methodologies also should match with the assessment. What can we assess? There is an array of qualities that we can assess: communication skills, knowledge, clinical skills, professionalism, and attitudes, and our ability to lead and to work in teams. So all these items can be assessed by various methodologies. So these are the how to assess students and trainees in medicine and health. These are mostly those areas which need assessment and which are to be certified at the end in the form of summative assessment. So communication skills, knowledge, professional behavioral skills and attitudes, clinical reasoning, clinical skills, teamwork, and leadership. Knowledge cognitive domains, as you all know, that knows, understands, applies, analysis, synthesis, and judgment, and all these levels need to be assessed at various levels of curriculum and various levels of studies. Skill or psychomotor domains recognizes, sequences tasks, imitates, performs skillfully, adjusts performances, and performs on his own. So these are the different levels, and these also need to be assessed. Like we have our e-log books in FCPS training, and they are all the skills that the student is doing. that they are entered into the e-log book, and the assessor or the supervisor time to time assesses whatever the student has learned in the form of skills, whether it is up to the mark or not, and the feedback is given to the student. As far as the behavior is concerned, awareness and response to the situation, appreciates, uh, then the rationalization, conflict resolution, and own personal ethics. So all these areas, as they need the training and teaching, they also need assessment from time to time. Methods used for the assessment of medical student. Excuse me. We have long essay questions, we have oral examination, short essay question, multiple choice questions, modified essay questions, patient management problems, observational assessment, OSPs, and TOEFs. So these are various methodologies which are used for various components of the curriculum, components of the teaching learning that are used for assessing all that. Validity and reliability should be there, because if by validity I mean that a valid test is one that measures the attribute or performance, that sets out to measure. For example, a multiple choice question paper is a valid way of assessing somebody's knowledge, because it can ask a lot of questions that cover the length and breadth of the topic. Whereas reliability is that test will be given the same results over and over again, and it's about how consistent the test is. And information about the assessment should be explicit, accessible, and transparent. And assessment should be inclusive and equitable. The purpose is that the student should not be sort of caught on the wrong foot. They should know what is to be assessed, when it is to be assessed, how far it is to be assessed in a particular exam, and what will be the nature of that exam. They should know everything about the type and pattern of examination, so that they prepare themselves accordingly. If it is a formative assessment, then there should be a discussion and feedback session afterwards. If it is a summative session, then they will have their results, and also they should have the details which component. For example, somebody fails the final test, he or she should know which component was weak, which component was strong, and how to prepare for the next term. So what makes a good assessment? Assessment should be aligned with the program and learning objectives. The amount of assessed work should be manageable for the students. Formative and summative assessment both should be included in any program, and timely feedback should be an integral part of any assessment to facilitate improvements in learning and teaching. It is time that we upgrade our assessment protocols according to the contemporary global standards and principles. In Pakistan, currently, we are facing some difficulties. We have WFME, and their recommendations are starting from the next year 2023 and 2024, and they want the professionalism, computer skills, communication skills, assessment of attitudes to be included in the assessment protocols. So our PMC, which is the main body for regulatory body, Pakistan Medical Council, that is working on that, and it has involved the universities, also the medical colleges, and they are trying to implement and modify the curriculum. And second thing is integration of the curriculum. So once we have the integrated modular curriculum, our assessment methodologies should also match with the curriculum that we are practicing for the teaching and learning of the students. So with that, I thank you for your presence and attention, and I am delighted to see so many audience here. The hall is full of audience, and this is a great thing that we have, at 5 o'clock. तो माशाल्लाह. तो क्वेश्चन आंसर तो इसमें मेरे ख्याल नहीं है कि हैं, अगर हैं तो ओके. मुझे ज़रा दूसरे सेशन में जाना है एक में जी. वो सर वो एक ही वक्त में 2 पे चेयर पर्सन हूँ मैं, यहाँ भी और एक और जगह भी. तो अगर इजाज़त दें तो मैं निकल जाऊँ. ठीक है. थैंक यू वेरी मच.
So, Bismillahirrahmanirrahim. We begin with the name of Allah, the Beneficent, the Bountiful. So, today, what we are going to discuss is DOPS, that is Direct Observation of Procedural Skills. We know that assessment is the driving force behind every training and teaching system. And every teaching and training system has a target in mind to achieve. And the system wants the person to be competent enough to perform to achieve the intended target. And in health system, that target is a better patient care. When we are talking about assessment, there are two terms which are used interchangeably, that is competence and performance. So once we are going to judge a person's performance in the real life, a practitioner in his or her clinic, the competence describes what an individual is able to do, the knowledge about the procedure, what he is able to do, but the performance describes what an individual actually does. So the performance based clinical analysis or the workplace based assessments, they are important, and we see them when we see the Miller's pyramid. It's the uppermost layer that does how a person actually performs in the clinic, because that is the product of our system, and we want that product to be knowledgeable and perform according to the expectation, to deliver what the system wants, that is a better patient care. So we'll discuss this, one of the workplace based assessment, DOPS. So assessment of a clinical competence can be either, just for a competence, can be either through OSCE, objective structured clinical examination, or OSLER, that is objective structured long case examination record. The difference is, when we are judging competence, we can use simulation, but in work-based assessment, we don't use simulations. We mean the actual scenario, the actual patients. And in that, we have many clinical evaluation exercises, case-based discussions, chart stimulated recalls, multi-source feedback, 360-degree evaluation, objective structured clinical practical examination, OSPE, task-oriented assessment of clinical skills, TOKS, that we do in our CPSP examination, that we actually see a person handling, but that is a little hybrid, because the patient may not be real and we are not judging in the real place. DOPS mean that you are judging the person in the real working place, and it should actually be a candid thing, but that's not possible practically. This is the one in which you want to see the person actually how he performs with the patient actually in action. So it's a concise, validated method of assessment consisting of a supervisor or assessor observing a trainee conducting procedural skill within an authentic workplace and providing a structured feedback on performance to promote learning. Now, I've made this definition out of few paragraphs actually. I've made all those important words together in 3 or 4 lines, which conveys a very vast meaning actually. Now, what can be assessed? It can assess a wide variety of skills, starting from applanation, tonometry to any skill like any surgical skill. But it depends on the level of the trainee and the settings that we have. How to undertake a DOPS? Actually, all the arrangements are to be made for a DOPS setting by the trainee himself or herself. The trainee arranges the place, the patient, and the place is decided whether a clinic or a ward or an OR, and he also procures the patient. He makes all the arrangement. He also arranges the score sheet or the pro forma for the assessor to judge, and then they determine the assessment criteria together, what is to be assessed out of this particular procedure. And आगे नहीं चल रही है. So the criteria are communication skills, knowledge of procedures, procedure skills, organization, documentation, management of any issues during the procedure. That means you manage the complications if you can manage, ethics and professionalism and boundaries. So these are the list of certain criteria through which you score the candidate. And a supervisor just observes the candidate, but he may intervene only when a safety of the patient is being compromised, because he's one of the experts. Then the supervisor or assessor rates the trainee over those criteria, and फिर नहीं चल रहा है, it's not working. Okay, so while scoring the trainee on that one rater scale, it's not necessary that you consider all the criteria. The previously agreed upon criteria or the criteria which are specific for that particular procedures can be taken, less can be marked as not applicable. Then the supervisor assesses and rates the trainee over a scale, and then after that immediate feedback is given to the immediate feedback is given to the trainee, and the feedback is structured and it is positive, formative, and in which good points are also discussed, the shortcomings, and for the future how to develop a new techniques or things. Okay, the total time for DOPS and feedback session should be around 30 to 40 minutes, but of course there are certain procedures which need more. And the trainee is expected to keep a record of all the assessment forms signed by both trainee and the supervisor, make it a portfolio, and then it is presented at the end of the semester or the training year so that it can be counted towards the final score. बेटा ये नहीं चल रहा, कोई और तरीका बताए, हैं? नहीं चल रहा, एक चल रहा है ना. So we judge the trainee from the basic to the advanced level depending upon the stage of the trainee. A basic first year, second year trainee, we keep him in the category of basic, and where low level of independence is given to the trainee and high level of supervision is done. And the trainee, it is expected that he would be able to perform only a few straightforward tasks. Then the proficient is the one who is the midway somewhere, and the advanced trainee is the one, advanced level is the one who is in third year, fourth year, maybe final year, in which we take off the supervision, we keep it to the minimal, and we can give the trainee more advanced and complicated tasks. And at that stage, we make it sure that we can trust him to be entrusted with complex tasks. All right. Anyway, so this is a pro forma or a score sheet which I have. It's a generic type, and I have made it myself, and I have adopted it from some other score sheets being practiced in Australia and UK and other places. So this is a simpler form in which I have shown some criteria, and then there is a score chart rating from. इस पे वो भी नहीं आ रहा. So we can rate. So we can rate any of these criteria, and if you anyway, so it is understandable that we can score the trainee from level 1 to 9, that if he's below the standard, how much below, if he beats the standard, how good, 4, 5 or 6, and if he's above the standard, how good above the standard. So this is how we score, and the most important part is the below the feedback. That is the most important thing, and it is signed by the supervisor and the trainee both, and it is kept safe by the trainee himself. So this was the one we can keep better now. We started working now. So in any assessment tool, we have to judge it over certain criteria, like whether it's valid or not. Yes, it's valid but its validity, for its validity, we have to repeat it over again and again over time. Any workplace-based assessment tool is to be repeated again and again to make it more valid. And the simple method to know whether it's valid or not, that the student is performing on the same procedure better next time. That means you are getting, if he scores better on the same thing when you do after 3 months, that means it's valid and it's fairly reliable also, reproducible, and it's generalizable also, that different patients can be presented to different trainees and same procedure on them can be done. And then it has a very good educational impact, because you are seeing the actual performance by the product of your training system. Acceptability or acceptable, well, there's a question about it, and I'll tell it. And cost effective, it's quite cost effective. It doesn't need anything much arrangements. It's done in the clinical setting. So generally it's a fairly good assessment tool for testing the performance and in real setting. So like all the other tools, there are certain outstanding issues, and acceptability in busy clinics, of course, or in private setups, it's very difficult that you observe in the way you want to observe. And it's relatively difficult to establish validity and reliability in real life setting because of different grades of specialty. Because what happens is that in DOPS, it's an arranged setting and you have to inform the patient as well. So in one way, you are not really 100% actually testing the skill of that trainee performing in the real life. But once done again and again, it becomes quite reliable and valid. Because it has to be actually a candid thing, a candid camera or something, actually watching the trainee or the practitioner, how he or she is working in the clinic. But it's near that. Its role of formative only or summative? In some institutions, there is still a question whether it should be a formative or summative. You want to rank the trainees on it, or you want to make promotion on the basis of this. So it's the decision of that training institute to decide where that training institute incorporates it in its training system. DOPS needs to demonstrate competence. Things are most of them have been incorporated, workplace-based assessments in the system, but still there is a transition in certain systems. And the students think from the day one that probably this is a pass. This is already a pass thing. So what they do is they keep everything and all those preparation till the end of the course. That is not what is required actually. It has to be about 5 or 6 times a year with every trainee, and then in the next year it should be increased to double, so that it's tried again and again. And can it be used at undergraduate level? Yes. With different settings, with different syllabus, it can be used. Thank you very much. It's different. No, it's hi. Ji.
My point of view is that whether we will be able to do it or not. And this is my main submission, is that we should start a pilot project in different, some of the centers in which it basically is going to start off this year, 2023 may start on it. And we need to have a understanding of this, especially the supervisors first themselves, how to done it, because about 5 years, it's almost 7 years ago, I started this thing 8 years ago in Armed Forces Institute of Ophthalmology, and took it from Royal College of Ophthalmology. उनसे सारा लेके हमने बनाया, लेकिन it lasted मैं की करा तुसी नजदीक है तो आ गई. So but unfortunately nobody is interested in doing it. It's only under compulsion कोई कर सकता है, ऐसे करने को किसी को दिल नहीं था. तो we tried to implement it, but it lasted there for a couple of years till I was there, and then as naturally it has got dying. But now we want to make it a part of the curriculum of ophthalmology part 2 residency. But my take home, what my point would be, can we look into it, what kind of questions which we are going to ask? What are the things which we really want to ask them during this competency, what are those questions, and uniformly all across Pakistan. So that will be the most important aspect.
Sir, actually, just my submission, when I was going through all these literature of all these things, so I was just thinking that our system of CPSP examination, the long case one, is it's a kind of hybrid. It's not purely it's oscillatory type of thing, in which sometime it's a simulated or standardized patient which is presented, but we are observing it, and we are not giving feedback to, of course, during the examination. So that kind of thing can be incorporated, because in our setups, like you observing your trainee and he's doing a surgery, as was the last slide, you just observe doing a cataract surgery, and then on the checklist you can rate, and then the most important thing is that you give a formative structured feedback. Now, sir, I would like that giving feedback itself is a big chapter. You know, one has to be trained to give a feedback. Structured feedback is a different horizon, actually. So you have to have a proper way to.
The thing is, I think so it's very important.
Yeah.
Whatever you're going to ask from the candidate or the supervisor should know exactly what should he ask from them.
Yes.
I think so. We have to make this thing also very importantly, that what is our supervisor expected to ask from the trainee.
Yes.
I think so. That is the first step, and to basically to teach him, he should only.
Invitation, and I think maybe some of the things I'm going to say will be very relevant to the last talk, and the last talk is a great segue into what I'm going to be talking about, something called the ophthalmic clinical evaluation exercise. First, I just wanted to make a mention that some of you may not realize, but for many years the International Council of Ophthalmology had one of their main arms was education, and there was new leadership, and they've decided to no longer do that. So a lot of us educators got together along with some other people and formed a new organization called the Ophthalmology Foundation. This used to be the ICO Foundation. It's now the Ophthalmology Foundation. The mission you can read here. I won't read it out, but basically two main things: helping ophthalmologists become better teachers and providing training opportunities through sponsoring fellowships. So the fellowship initiative is also in combination with the IOFF. I think there are 85 short fellowships, 3-month fellowships a year, and several 1-year fellowships. The second initiative is education. I'm the chair for that, and that's to maximize the training ability of ophthalmic educators to enhance the skill of ophthalmologists and improve global eye care. Special focus on low resource countries. So we do a lot of the things like assessments and teaching skills and so on, exactly what these sorts of meetings are doing right now today. We have many programs, and I only talk about one that might be of interest to all you educators. Monthly modules, they are recorded. Each module has 3 international speakers that give a 15 to 20 minute narrated lecture on a topic. Those 3 lectures are available at the beginning of each month. And then there's the participants take them, do the homework, and at the end of the month, we have a live webinar to go over the homework and answer questions from the participants. This started July 1st, 2021. This month's our 18th module. They are not sequential. You can take these at any time, and you don't have to take all of them. You can take a couple of them. This is just an example of the types of things that are included in the topics. There's on professionalism and ethics. We just did one on ethics last month. So I just wanted to mention that. Ophthalmology Foundation, I'm happy to tell you more about it. I'm on the board as well. The OCEX was actually the topic of my master's degree in education. And I'm going to describe the need for the OCEX and how to use it. Now, the initial publication was way back almost 20 years ago. And this was a form of ADOPS, but specifically for the student-patient examination. And we did establish validity by having 20 US ophthalmology program directors review the document, review the rubric, which I'll show you. And then we had videotaped interactions and had them score that with the OCEX to produce to show if there was inter-rater reliability. So we showed both content validity and inter-rater reliability. Then some years later, we said, gee, this was developed in the US for US audiences. Let's revise this with an international panel of authors and do the same thing. And so this was a subsequent publication. I said accepted, I'm sorry. It's been published, the ICO Ophthalmic Clinical Evaluation Exercise. And this is the way it looks, although it is not advancing. I can see it down there, but I don't see it up here. I'm sorry. I think I went through, there we go. So this is part of it. Now you can see this is on the left-hand column. It's got the various steps of, in this case, taking a history. And on the top, novice, beginner, and competent. But unlike the forms we just saw, the DOPS, where there are blanks, letting the assessor check the blank, this describes what it means for the introduction. So for instance, for competent, introduces self, explains their role in the team. So this not only allows makes a more objective document, because this is not up to the assessor to say, oh, I think that's a 6, or I think that's a 2. It tells you, the assessor, what to do. They see the behavior, they circle the box. But it's also a much better teaching instrument, because we don't keep these secret. We give it to the residents at the beginning and say, here's what you need to do. Read that competent column and do that. And then it makes the assessor better at giving that important feedback, because they can look through this and oh yeah, they didn't do that, or they did do this. And it allows the delivery to feedback. And my doctors say, wow, this initially they look at it, oh, that's long. But once they use it, they say, this makes me a better teacher. I'm giving much better, more the 8-part components. Next slide. Unless I can do it. I'm sorry, go back one. I did it too. Go back one for a sec. And then interpersonal and communication skills. Were they empathetic, respectful, explain the diagnosis? Did they explain it well? Did they use language the patient can understand? Next slide. And then after you're back one, after you're done with the presentation, so you sit there in the chair and you watch. I go into the room first. I tell the patient, I'm about to assess this young doctor. And usually the patient's like, oh, good, this is going to be good. I want to participate. You ignore me. I'm just going to sit there, and I'm going to have my clipboard, and I'm going to be circling things as I watch. At the end, you walk out of the room, and this is what we normally do, and the resident would present the patient to me like I wasn't there. Very interesting what you hear, because you were there, you heard it, you saw what happened, and then they present you, and that's not what I heard. And so you then rate their case presentation, which helps a bit with medical knowledge. So the questions that were brought up earlier were the DOPS. Is it feasible? It doesn't cost any money, but it does cost time. And that's where the docs who are already busy, I'm not doing this, this takes too long. It is valid and reliable. We've shown that with the validity and reliability studies that we've published. And it has more, I think, educational benefit. How do we get our faculty to do this? And that's what you were just asking. How do we get them? You need to train them. They need to understand why this is important, how it helps the student, and hopefully how it helps them be better teachers. We use it, let me see, yeah. So we use this particular rubric early in the training, because this is about taking a history and an exam. Hopefully by the end of the first year, the resident can take a history and do an exam. So we use it at least 3 times in the first year of the resident. Now, if the resident's always missing or not doing well on part of it, do well, not the whole thing. So it shortens it for the assessor. And that's how we do it. And then as long as they can do it 3 times, as long as they're successful at the end of the year, we don't do it again, because it's just the history and the exam. So the summary for this and for the previous lecture was that you must measure competence. We can't measure history taking and clinical skills with a multiple choice question exam. You have to have workplace-based assessments to measure these other, I would argue, maybe more important things than memorization of, 10 reasons you might have papilledema. We want to know, can they identify papilledema? And do they know how to manage papilledema? I thank you for your attention on that. And we can go right into the next lecture, which is about a different kind of a rubric. And I'll explain just a bit more. This is a very expert audience. And so I won't take too long on this. But so I was asked to talk about surgical rubrics. And so my objective is to describe why surgical skill rubrics are necessary and describe how to use an assessment rubric. So this is a general surgery rubric from the Royal Australian College of Surgeons. Again, all of these rubrics will have on the left column, the surgical rubric, steps of a procedure. They should, at least. And then a rating scale. And I can't remember what the UBS, I'm sure the last column, AS means good. But like a lot of rubrics, there are all these empty boxes. So you're letting the assessor totally decide themselves, oh, I thought that was good or okay or not good. That is not a good rubric. So next slide. Rubric is an assessment tool. This one definition is an explicit set of criteria used for assessing a particular type of work or performance. And it should consist, I would argue, of three things: dimensions, for surgery, the steps of a surgical procedure; levels, 1 through 9, novice to expert or novice to competent; and then these, what we call behavioral descriptors, that make this more reliable and a much better objective measure of assessment and teaching. So here's the first OSCAR that we created. OSCAR stands for Ophthalmology Surgical Competency Assessment Rubric, OSCAR, OSCAR. And here's the beginning of the one for phacoemulsification that was published a long time ago. Step number 1, draping. 2, incision and paracentesis. There are 20 steps. So it looks like a long document. We picked a modified Dreyfus scale for levels of achievement: novice, beginner, advanced beginner, and competent. But then we didn't just leave these boxes blank. So these were created, all the OSCARs were created by a panel of international experts, the authors, reviewed by another panel of international experts to create content validity. And then some of the OSCARs, not all, we videotaped procedures. We had trained people with the OSCARs, grade them to show inter-rater reliability. And they have high level of validity and inter-rater reliability. So our goal is to produce valid and reliable assessment tools for surgical skill and create a behaviorally grounded rubric, no blank boxes, that will allow teaching and assessing. So just like with the OCX, the residents get the OSCARs and we tell them, look at the competent column, do that, that's what you need to do. So we worked on these through Google Docs, created a rubric, and then ultimately published a number of these. That's the QR code for the phacoemulsification rubric. Let me get that picture of that. I think I've got another. You get it? And then shortly thereafter, we published a few more, and then we published a lot more. So all of the OSCARs on the left have been published for all that. We're trying to create a toolbox of the commonly done ophthalmology residency procedures. In progress, we still have a few. I don't want to tell you how long they've been in progress. It's been a while. And then recently we just published one for open globe, ruptured globe, pterygium, and tube shunt. You may recognize our first author on this one. This is actually not quite published. It's just in press for pterygium surgery. Each of these OSCARs created the same way, behaviorally grounded rubrics. There's a whole bunch of them. And every month or so, someone emails me and says, hey, we need one for tube shunts. So the guys at Hopkins emailed me, and I think we want to do one for tube shunts. All right, let's get a panel together. And so we keep doing them. And we'll keep doing them. And now they're taught, I think the most recent one was amniotic membrane. I just had someone email me earlier last week and said, hey, what about amniotic membrane? We're going to Vietnam and they do a lot of that over there. I said, no, we don't have one. Okay, let's make one for amniotic membrane. They take a while to make. It depends on the authors, and it's like herding cats sometimes. And so that's the Oscars. Now, a couple of tips to ensure the intent is understood. You need to make sure that your assessor, because you think they don't want to do the stuff in clinic, guess what? They don't want to do this in the OR either. So my attendings, when I gave it to the consultants, I gave them this and they said, oh my gosh, look at how long this is. But once they read it, I mean, they're experts at the procedure and they say, oh, well, yeah, I know all that. But once they read it, they're more likely to do it. But the way we really got it done was we gave them to the residents. We leave them in the operating theater and the residents understand these are for me, not me, the consultant, me, the resident, because this makes the attending give me much more specific, formative feedback. And so the residents, when I ask my consultants, will you do this? But if the resident says, will you do this for me? Yes, they will do it for the resident. Not for me. They'll do it for the resident. How often do you do them? I don't know. It depends. It depends on how many cases. If there are some countries where residents only do 20 cataracts in their whole career. I do it every cataract. If you're doing 300, I would do it maybe every couple cataracts to begin and then less and less and less. And we're working on a phone app with a spider diagram that'll have the 20 spokes. And so what we'll do is it'll average the last 5 cases. At the beginning of the case, you could say to the resident, show me your Oscar scoring. And they look at the spider diagram and look at it for the divot, right? Because around the outer edge is the competent. And then in the middle will be the beginner. So if you got a divot, oh, that's step 5. What's that? Oh, capsulorhexis. Let's concentrate on capsulorhexis today in the operating theater and see if we can't get your spider diagram to be a nice big circle instead of something with all these divots in it. And the residents definitely need to know this is formative feedback. Now you can make any formative assessment summative. It's just depends how you use it, right? So you could make an Oscar summative. You could say, well, we're going to be doing these throughout your training, but your last 20 cases, you need to average at least 90 or whatever you want to say. If it's a routine case, not a complicated case, you could make it summative if you want. But really the intent when we made these was formative, good formative feedback. And my surgeons now say, boy, this has really made me much better at giving very precise, structured feedback to my resident. So you got to enlist the residents, get them to drive this, because if they do, as long as they believe, as they should, that this is a teaching thing for them, everywhere in the world I go, residents say, well, we don't get enough feedback. I don't know how, I think I'm doing all right. I don't know, but I don't know because they don't tell me. So residents like this. So in summary, residents like this. So in summary, surgical rubrics attempt to make an assessment more objective. It helps the assessor with the specific examples to make them better teachers, better at giving structured feedback. It tells the student what is expected. Someone said, don't keep it a secret. It's not a secret. Here's what we expect you to do. And it provides that opportunity for prompt, structured feedback. And again, we could do a whole workshop on how to give good feedback, but this, I think, enables that. I thank you for your attention. Are we taking questions now or?
Carl, can we use this couple of minutes for you to make us wise? General Mazhar is here regarding the blueprint for just the broad outline for College of Physicians and Surgeons 4-year certification training program. Just a brief outline.
As I said, Carl, that we are in the process of making all these kind of things, and as a being a member of ophthalmic member of College of Physicians Surgeon, where we do all our post-graduation education over there, I can extend you that can you help us in getting this thing done. The other thing, I can also take the opportunity to invite you. We have got a medical education conference going to happen. It's a bit early in the month's time, between 10th till 9th till 12th of January. I don't know whether you are busy or whatever it is, but I can extend an invitation. You can personally come to Karachi if you feel like it. I can send it the email tomorrow to you, where we are doing a whole kind of a medical education program of all the specialties. And in ophthalmology, as we are just in the infancy of this thing, we would like if we can show to them that this is the possibility, and then in future we can draw different programs out of it. So if you have got a time over there, but in case you can't come, can we invite you to even on a video conferencing, and so that with all the group over here, you can share your experience we've already done, and so that we can inculcate it into our
I'd be honored to come. I'll have to look at my schedule and see. I don't have a lot of travel in January, I don't think, but I got a lot right after January. But yeah, I'd be honored to come. And I think regarding the United States, and we have something called the milestones. The milestones, and they've just been redone. I was one of the first the authors of the first milestones, but they do have milestones that are have more specifics about surgery. And in the milestones, which are what they sound like, as a beginning resident, you should be able to do this in all the different areas in ophthalmology, including surgical procedures, and as a graduating resident, this. And then they list the types of recommended assessment tools, OCEX and OSCAR. So that's what the US recommends, these tools. And these tools have been translated into multiple languages and are used around the world right now. The rubric, those rubrics with the behavioral grounded descriptions are hard to create. It takes time to do that. And you don't want to use that kind of a rubric for something that's really simple. And so you've got to decide, well, is it worth it? We sort of had that conversation about the surgical procedures. Gee, residents almost never do a lot of vitrectomies. But someone said, yeah, but the fellows do. So let's do one for vitrectomy. So we did one for vitrectomies. But you wouldn't do one, say, for tonometry, probably. That maybe just adopts without the behavioral. So you want to make sure that the toughest things are the ones that need the most work, the most description, most surgical procedures, for instance. So,
OCX and stop the thing, and where do you start the rubric and stop the rubric?
Yeah. Well, so we start the OCEX. We use almost exclusively in their first year, and as long as we expect them to be competent. It's just taking a history exam, but we expect them to be competent by the end of the first year doing that. If they're not, it usually means there's something they're just not. But usually by then, it's fixed because you're giving them this very specific feedback. Here's what you're not doing. So it's very unusual that someone is not competent in the competent column on that by the end of their first year.
And how do you space them? Like every 3 months, every 6 months?
Yeah, we give them a month or so after they're in the clinic, and then a few months later. Now, if someone's not doing well, we might space them because we think, maybe we're going to do more than 3. We space them together a little bit.
So it's like 4 to 6 DOPS in the first 2 years, and 4 to 6 OCX roughly.
I'd say it's, really, it's probably usually 3 OCX in the first year.
Okay.
And then usually none.
All right.
So it's
and
not.
DOPS is the same?
So we don't really use something called DOPS.
Okay.
Not really. That's more just, And there's a question about whether we should be using more DOPS. And then the OSCARs are used later, as soon as you start doing cataract surgery, whenever that is. Our residents start doing assisting, but start doing parts of surgery sometime in the second year.
And how do you stagger the OSCAR rubric in terms of its completion? You can take it in parts and then complete it.
Sure, you can, because you can use any part of that. Like you said, if you're teaching components of the case, your second year resident might only be doing the easiest step. Obviously, you can't do the whole form. You just do the steps that they're doing.
I personally feel that if you can do complete 2 or 3 rubrics in third year, that should be good enough.
It depends.
You want to give them a structure.
It depends on how much they're doing in those years. So our residents, at the end of their, it's really at the end of their second year, they've done about 25 cataracts, 25. So hopefully we have some number of Oscars for that, because that's when you really need them most. I think when you're starting, that's when they need the really more frequent. And then once they get going, you realize, oh, they're pretty good on steps, the easy steps, but they're not that good yet on the hard steps. So let's concentrate on the hard steps. And then ultimately, of course, you want to see everything in the competent column to the right.
So we can summarize for General Saab aapki gosha-guzar yahi hai ki I think we can summarize that the faculty can actually target for 4 to 6 mini CX or OCX ICO for the first and maybe second year if you
Yeah,
want to
it
spill it.
depends
So
if they need
before IMM, they should be doing 4 to 6 or 8 OCX.
Well, as you know, it's always a question of, will
Yeah.
they do it?
Yes.
And do they need to do it? Because you don't want it.
Yes.
And do they need to do it? Because you don't want them to do it. And if they might say, well, after the first 3, they're fine. They're competent. Why are you making me do more of these?
Brilliant. And 2 or 3 Oscars to start with, focusing on FACO, let's say.
Yeah.
To
Or if there's something else. I mean, that's what most residents are doing a lot of, at least in the United States, although they're doing some number of all the other things too.
So we have to start with the minimum and then we take it from there. And that
Yeah.
has to be debated in the faculty of ophthalmology. Probably that's the best forum where you can invite him on video link. But I think you will really enjoy the conference with the College of Physicians if you come make it, Anthony. That'll be it.
Yes.
Thank you.
Okay.
Brilliant.
Okay.
We always learn from you.